Welcome back, everybody. I'm Dr. Steve Silvestro, pediatrician and host of the Child Repair Guide, and my guest today is Dr. Michael Daignault, an LA area-based emergency physician. Mike, thanks so much for coming back to the show.
Thanks for having me again. Good to see you.
Yeah. So we first talked, I believe it was March 1st, and we
Yeah.
talked about coronavirus and what was sort of a burgeoning situation, infection in the country at the time. And I remember at the end of that conversation, you had said, "Steve, we're gonna have to talk again in a week because this is changing so quickly." And we're now just about 6 weeks later. This is April
Mhm.
15th that we're recording, and it's a whole different world right now.
Yeah.
Um,
There's so much to unpack.
yeah. So I know that California, in addition to Washington State, were and New York, were among the first places that were hardest hit. Um, what have these last 6 weeks looked like for you in the emergency department?
I mean, God, where to start? Um, well, like from a 10,000 foot level view, what you mentioned about where it started in California and it kind of circumnavigated the globe the other way, west. I mean, initially, we had the first couple cases on the West Coast, and then it like disappeared,
Hmm.
and then it went to China, and then it went to Italy, Iran, Korea, and then Europe, and then New York, and then it kind of came back to California.
Yeah.
So, I mean, that's been interesting. I think we always thought that we were going to be one of the more harder hit areas just because, I mean, there are direct flights from California to Wuhan every day. I mean, or there
Wow.
was.
Yeah.
And so, we'll have to talk later on about the articles that came out recently about, if California had this like herd immunity because we were exposed earlier. We'll get to that
Huh.
in a bit. Um, from the ER level, I think we just had all this time to prepare, and it was kind of like this eerie silence because we were telling people, stay out of the ER, like only come if you're really sick. We need to take care of all these like anticipated COVID-19 critical patients, and it was like, okay, next week's going to be the surge, next week's going to be the surge, and essentially that surge hasn't happened yet. And I'm
Hmm.
saying yet because I mean, anything can happen, but it looks like it didn't materialize, and our volumes were super low, and the patients that we would get were COVID patients, but in a bizarre turn, I mean, we were seeing less heart attacks, less strokes, less appendicitis, which was kind of bizarre too. It's like, where did they all go?
Yeah, it's gonna be really
Um,
interesting when that stuff gets teased apart. I mean, were these folks managed somehow at home by their primary care docs? Did they, something bad happen and we just, haven't gotten those that data yet? 'Cause, yeah,
yeah,
it's
what
interesting.
happened?
Yeah.
Like, I don't know. It's bizarre because they must have gone somewhere. I mean, a lot of the primary care doctors' offices here were closed because they just didn't have the PPE.
Yeah.
So yeah, I mean, that's like going to be further down the road. So, it just gave us a lot of time to prepare, and we just kind of watched what was going on in New York. And, from the ER level, I think, we saw how in Italy and New York, the initial um, treatment model they followed was, oh, your oxygen level is really low, you're hypoxic, you need to be intubated.
Hmm.
And so they intubated everyone, and then everyone was put on a vent, and then it was all about vent shortages, and we need vents. We don't have enough vents. We need to make more vents. Talking about this like World War II level rollout of vents, like you know that
Yeah.
kind of thing. But then we realized that that vent strategy was actually not working, and we were seeing high mortality, like 30, 50, 80% of people. Once you went on a vent, you didn't come off it, or you passed.
Wow.
Um, and once we realized that, a lot of these patients were talking on their cell phone, and their oxygen saturation is 60%.
Wow.
And we were like, oh, you can put your phone down so we can intubate you.
Huh.
And then people started to step back and be like, this doesn't make sense. Like we thought it was, when you have pneumonia and you go into ARDS, which is like acute respiratory distress syndrome, And you go on the vent, you have particular vent settings that this group has come up with. But the whole key to ARDS was distress. I mean, these patients aren't in distress. And so we started to step back and say, hey, they're not fitting this pattern. They're not doing well when we apply these settings. Let's think of something else. So then we started using high flow oxygen and proning them, putting them on their stomach, putting them on their sides to recruit alveoli. And that's been, that'll go down as probably the biggest game changer with this. I mean, I know we don't have like a definitive treatment, but to save time on the vent or even prolong or even prevent altogether being on a vent has been a huge game changer. So we've, rolled out that strategy here. We're using that now, and that's all based on the experience that we saw in New York and Italy.
Yeah, that
crazy
proning technique has been, there have been a few articles about that, even in just the straightforward mainstream media recently.
Mm-hmm.
That this idea of having somebody lie on their stomach face down, with stories of people's oxygen just like shooting right on up just by doing that. And the idea is that you open up more of your lungs and get more air in doing that. It's pretty remarkable.
Yeah, I saw this tweet yesterday by an ER doc, and he had a picture of, I think it was like some Tour de France cyclists going up the mountain, and how they were leaning over their handlebars, like at, if you're at high altitude, they're going up a mountain, that's when they're really hypoxic. And he was like, this has been evident, just watching sports, like when people lean forward, I mean, they're almost like proning over their handlebars. There's a reason we naturally do that. You don't even think about it.
Yeah.
But if you think about when you're biking and you're going up a hill, you don't do this. You like lean forward and kind of like up. Pretty crazy, right?
Yeah, because you're saying that now, and one of the things that we learn about in pediatrics is epiglottitis, which is where the epiglottis, the little flap that covers your trachea when you swallow, gets infected and swollen. And it used to be a lot more common in young kids because it was caused by a bacteria we now vaccinate against, Hib. And the classic thing you learn about is that the kid is tripoding and leaning forward. And the reasoning that we were always taught was that position helps to open this part of the airway, which it does. But yeah, I bet it's also a natural response to just breathe better and get more oxygen overall.
Mm-hmm. And it's interesting when you tell patients that we're going to have them do that. And so it was first we were proning, and then we were doing you'd kind of be, I think what they called it was like roast. It's a terrible name. It was like like pig roasting. So basically you go to your stomach, to your side, to your other side, to your back every 30 minutes. Wow. And so that's kind of taken over from just simple proning. So it's this continual movement every 30 minutes. We reassess that every hour, because within an hour you're expected to see a huge improvement. Wow. And you tell patients, hey, like, we got to do this to prevent you from being intubated. I mean, they're all for it.
I bet.
So, and they're with it and they're talking to you, so it's an easy thing to communicate to them to try to do, and it works. And it's been remarkable. So
let's I think what might be useful for everyone who's listening or watching at home would be to know a little bit more about testing. And testing has been this problem, this buzzword, this huge chunk of the conversation for this whole 2-month period. Partly because what's available and the rules that are used seem really to vary by area. I know that here in Maryland, it's April 15th, and unless there was a new one put out today, the Maryland State Department of Health has not put out a letter of guidance for clinicians since something like March 26th.
Wow.
So, yeah. And so with those guidelines from 2.5-3 weeks ago, the recommendation was that we should only be testing people who are hospitalized, people who live in a nursing home, healthcare professionals with symptoms, and people who have a diagnosis already or condition already, and whom a diagnosis of COVID would change what you would do. And that was it.
Hmm.
There was this idea that some of the private testing as it rolled out was a bit more just, you could use your own gut. Um, but the official guide, but they still were saying, we'd still like you to try and stick to these guidelines. And there's been no new recommendation since. Um, so a lot of the conversation around here has been, testing has gone down because we're primarily just telling people that as long as you are doing fine, it doesn't matter if you get the diagnosis or not. Just stay home and look out for X, Y, and Z. Um, I don't know what sort of what's happening at least at the ED level out where you are.
I mean, same situation. I think, personally, that's been one of my biggest frustrations
Yeah,
is
yeah,
the limitations in testing. Just because we haven't had enough kits, we haven't had enough um, even swabs. Some point like to do this. It's not just about the test; it's the reagents, the swabs,
that's right.
the lab personnel. Like not all the hospitals can run the test; they have to be sent out, and so California has been this patchwork of, like you said, it's a total free for all. And that goes back to early on when there was no federal guidance, and at least New York decided to they came up with New York State came up with their own test and they just got that approved. California had that option, but they went with this some kind of archaic CDC test that was a disaster, and so we were like super behind.
Yeah.
And then to go to your question, like if you have limited testing criteria and it seems like you're not doing enough tests, then how do you know what your baseline is?
Well,
Like,
that was one of the big arguments for a long time is that if we're going to say that 25 to even potentially 50% of people are asymptomatic, let alone just
mhm,
mild symptoms, and the majority of people that you are testing are coming up positive, that means you're not testing enough people. Um,
right.
Another test that's really been a buzzword lately is this idea of antibody testing.
Oh yeah.
Can you speak to that and describe what that is and
Mhm.
why that's going to be such a key piece of all of this moving forward?
Yeah, I think I feel like that just blew up in the last week that,
Yeah,
everybody's an immunology expert now.
yeah,
Um, so what happens if there's two big immunoglobulins that are important. There's IgM and IgG, and IgM will show up. I'm simplifying here, but IgM will show up when you have a certain infection, and then IgG is made by your immune system later on to show either you've recovered for an illness, but IgG would also be positive if you got the vaccine. So people are looking at this now because in the last week, everybody's talking about, all right, when are we going to go back to normal? Like, what do we need to open back up society?
our patience is
And
running out, it seems like.
yeah, this
Yeah,
is one of the criteria. I mean, we have to have more widespread regular testing for the virus than we already did, like you said. You have to be able to trace all contacts, and the hospitals have to have the resources to deal with any other potential surges. And then the fourth big criteria is you have to have some kind of serology test, like an immunoglobulin test, to determine who can go back to work. Like if you're positive for IgG, then you presumably had the infection recovered, and the more people that have IgG, then you get that herd immunity. That means that less people that weren't exposed are going to get infected. The problem is there's twofold problem. There's only 3 FDA approved tests as of today,
yeah.
and I don't even know where those are, how you would even get them. You can order this test online, but it's like, how do you even know it's not validated? You don't even know if it actually checks for the new coronavirus. I mean, I heard some reports that some of the ones you can order online, they check for all the old coronaviruses. So you're giving people this like false negative test.
What you mean by order
Um,
online is that there are some that are being marketed as if they're like direct to consumer, that you can just buy
yeah.
this, finger stick
Hmm.
it, and mail it
Yeah.
off. And yeah,
But you could
these
just
are
do it at
not.
home, actually.
Yeah,
Like you get a result back within minutes. It's crazy. Um, The other concern I have is I just read this. There was a New England Journal article that came out on Monday, and it was a limited study. It was like 200 patients in China who had mild to moderate illness, were hospitalized, and they did their IgG testing. Again, IgG is the one that shows whether you developed antibodies after you were sick.
Mm-hmm.
30% of those patients had like minimal IgG, and 6% had no IgG.
Wow.
That freaks me out
Yeah.
because I'm like, well, what does that mean? Why would you have, I mean, just from like our basic medical background, like why would you be infected with a virus? Obviously, you fought it off, you would make antibodies, and then the antibodies disappear. So does that mean that you can get reinfected? Are there multiple strains? Like that's super scary to me. So, I mean, obviously that's a limited study, but does that tells me that this could be like Dr. Fauci said, this could be a seasonal thing.
Yeah.
That you could get it again. You could even get it in the same season. And I would hate for people to get a test result that's, oh, it's IgG positive. I've recovered. I have the antibodies and then get sick again. So, I mean, it just goes back to the point we just still don't know enough about this virus, unfortunately.
Yeah. Yeah. I mean, it's kind of like with the hopes of a vaccine. We can talk about trying to get this stuff streamlined and out quickly, but this is such a big issue and such a big universal deal that we've got to take our time and just do it right. And the same goes with testing the antibodies.
Mm-hmm.
Let's talk about signs that somebody should look for whether they know they actually have a diagnosis of coronavirus, of COVID, or they think that they might. What should be someone's signs that they should seek extra help and go to the ED? Because again, I was on call this past weekend, and I am telling just about everybody that has almost any sick symptoms, because if you read, this is the really crummy thing with this virus. At first we said it should be fever, aches, and a dry cough, and now it's expanded to, especially in kids, include GI symptoms and head to toe. So I'm telling everyone just to assume that you have it, and therefore then look for these certain signs of distress. What would you say are some of those signs that somebody should be on the lookout for if they feel ill?
When people come in now with a confirmed illness, confirmed positive test result, whatever, if they're saying I have shortness of breath or chest pain, even flank pain. We've had a couple surprises lately at the ER where patients would come in as flank pain and be triaged to a not a negative pressure room. And
Thanks.
The presumption being, oh, it's a kidney stone, it's a urinary tract infection. And then they would get a CAT scan of their abdomen pelvis, and the CAT scan would pick up that bibasilar opacity in the lungs that looks like the COVID. So like it's really hard. It's definitely a conundrum when it comes to what symptoms to look out for. But to me, it's the shortness of breath, the chest pain, shortness of breath, especially on exertion. Like you're really tired going up the stairs, you really get short of breath doing that. Plus fevers. But I mean, we've seen, people can get altered from this. Like they, mentally, we think that maybe the virus like affects your central nervous system. We've seen patients come in. The first sign of illness is they're getting these lesions on their feet. This is what we're hearing from orthopedists now, like these weird rashes on their feet. And then, as you probably read, the ENT Society put out that article about how loss of sense of smell and taste was the initial sign. So I mean, it's a crazy virus. So. But what we do, if people come in and, they're not feeling well and they already have a confirmed diagnosis, we send them home with pulse oximeters, and a home health nurse will call them and just have them check it a couple of times a day. So, I mean, I don't know what other places are doing, but really it's the hypoxia that we're looking for. So, and if your oxygen is really low, you're going to have really bad shortness of breath and chest pain. So,
let's kind of like tease that out a little bit. I think that a lot of folks are scared to go to the ER right now because they're afraid that if they don't have it, they're going to pick it up. And so I find it always helps to give folks almost a play-by-play of what's going to happen if you go. What, like, walk us through the process of someone walking through the ER doors. Um,
No, I'm glad you brought that up. I mean, people, like I said earlier, like our volumes are super low and people are definitely scared. And people call the main ER number and ask the tech all the time. They're like, are you guys seeing non-COVID patients there? Like, if
hmm,
I come in, am I going to be put in an area separate from the COVID patients? And so people are definitely scared. The one thing that I read interesting, which sounded kind of like good news, I hope, was you're going back to what you said about the 30 to 50% of infected people being asymptomatic. At the initial stage that you contract COVID-19, like your viral load is probably really high, and that's when you're super infectious to other people. And I
yeah,
think that's behind the whole everybody needs to wear a mask and everybody stay at home. But as you go through your 14 days of assuming that you're going to get sick once you get it, like day 10, 11, 12, and then the sicker you get, they think that your viral load is actually less. So I thought that was really interesting. So like in terms of, us being healthcare workers in the hospital, presuming that when people come in, they're sicker, then our potential exposure is perhaps less.
yeah,
I don't know. That was an interesting. But going back to your point, um, I mean, every ER has crazy screening processes now to identify anybody suspected, and so we obviously all have a high suspicion. If you say anything that you have any kind of upper respiratory infection signs and symptoms, cough, shortness of breath, chest pain, everybody gets a surgical mask put on them, whether they're coming in for an ankle sprain or chest
yeah,
pain or abdominal pain. That happened about 3 weeks ago, which was really great. So, and we're all, wearing N95s and full gear for every patient, just because, like you said, we just assume everybody has it. So, um, for the average person to come in, I think they need to know that, after whenever you leave a particular room, a patient leaves a room, that whole area is wiped down and cleaned and sanitized. And sometimes it takes a while for us to do, but that's being done, especially if it was like a COVID-19 patient or suspected COVID-19 patient. Um, so, I mean, yeah,
yeah,
it's hard to quantify what your risk is just coming into the ER. I mean, I can't. It's probably a little higher than if you were going to the grocery store, but I mean, I think most of the people you're going to be around in the ER are going to be wearing masks, and it's going to be a more sanitary place than going to the grocery store. I mean, personally, I feel safe when I'm at work. When I have to go to the store, I get really anxious. Like I don't
yeah.
like being in the grocery store these days. So, and that's coming from an ER doc. Like I feel comfortable in the hospital,
Yeah.
but I'm scared to go to Trader Joe's. So, yeah. But I mean, I think people just, if you don't feel well, you should still go to the ER. I mean, leaving your house is a risk, certainly, but got to do what you got to do.
Yeah.
You can always call. I mean, I think everybody in the ER would be more than happy to talk to you. I mean, I've been talking to a lot of people on the phone
Yeah.
lately just because our volumes are low. So just give your ER a call.
Same here in the primary care side. I mean, we it's a conscious decision. I mean, we're bringing in only really infant checkups because they need the vaccines. We're doing the same. We're wearing full gear for everybody, sick or well.
Hmm.
You get a mask at the front door. We're having just one parent come with a child, checking people's temperatures even when they first walk in.
Hmm.
Um,
Yeah.
I think that everyone is trying their best to keep their environments as clean as possible. Um,
That's a
there,
good point, actually, about the one parent thing.
yeah,
Most hospitals now, there's no more guest policy. So, um, and, you know, uh, it's funny how you think about how culture in hospitals and offices are going to change after this. And do you think about how many people come in with patients sometimes because we're trying to improve, patient satisfaction and stuff like that. But
yeah,
when you think about it, you're coming into a place with a lot of sick people, and does that policy ever really make sense? And what's going to happen going forward? I mean, a lot of us now, I mean, we kind of like the fact that we have less random people walking around the ER. I mean,
Mm.
for their safety and for ours. And so, I don't know. It just makes me wonder how that's going to change in the future.
Yeah,
Uh,
it just means a lot of reevaluation of
sure.
procedure and culture too.
Yep.
Um, there's been a lot of various rumors, a lot of snake oil being passed about online, some from very prestigious political institutions as well.
Yeah.
um, I believe actually just today I saw an article of a French study showing
Yep.
that right hydroxychloroquine did much more harm than benefit.
Yeah.
Um, any of those sort of rumors or things that people may have come across online or from friends or elsewhere that you think is important that we dispel right now?
Well, I've struggled with this when I've been asked about this for local news here because I think everybody just wants some hope.
Yeah,
They want to hear that something works, and um, eh, every the stories are all anecdotal,
yeah,
and it's a doctor saying, "Oh, I have 10 patients and I gave the drug to, and in 8 to 12 hours they all felt better," but they could have just gotten better on their own. And if it was something that didn't have a lot of side effects, that was relatively benign, I would say fine. But hydroxychloroquine and chloroquine are not like the best drugs. I mean, they have serious cardiac side effects.
yeah,
And I've said, the last month we need randomized control trials where you have two groups of patients. One patient would just get, like we talked about before, proning, oxygenation, and the other group would get proning, oxygenation plus some of these medications like hydroxychloroquine, and you can see, okay, who survives longer, who leaves the hospital, gets off the med, etc. But then I started thinking the last couple of days, like, do we really have time for that? I mean, is
yeah.
it worth just giving it a shot? Um, so I really don't know. Like, if I was talking about this with my colleague, we're like, if we were admitted, God forbid, COVID-19, and we had to choose between, because right, I mean, some hospitals are basically saying, all right, we're going to give you either a combination of azithromycin, hydroxychloroquine, or remdesivir, which is the other antiviral. You can't have both because I think what's happening is that these drugs are approved for compassionate use in the sense that they have to be a part of a study. Like the hospital has to show that they're looking at it like a study. You can't have both because they're trying to show, all right, what are the benefits of these actual drugs? So, I mean, those are the two big ones, and what is the other stuff that we were reading about? The things that I find interesting um, is especially for young people. Like I think everybody's like, well, I'm young, I'm healthy. I'm hearing about young and healthy people getting sick from this, and I
Yeah.
think we need to talk about why that happens.
Mm.
Um, and it's basically your immune system just overreacts, and you have this cytokine storm, which is all your immune cells rushing to your lungs to fight off this infection. But that's too much fluid and cells for your lungs, and you just get overwhelmed, and that's why some of these young people pass away. So one of the drugs is focused on limiting that cytokine storm, like affecting that one. I think it's interleukin 6, whatever that causes that. If they can inhibit that, and I think that shows a lot of promise.
Yeah.
That's a treatment that's been around for a while with, I think some inflammatory diseases like rheumatoid arthritis and stuff, and so that has potential. And going back to your question about all the stuff online, the only things that I've seen that show some promise are vitamin C and vitamin D. There was a study that came out over the winter about vitamin D and coronavirus, because obviously it
Hmm.
didn't include this new coronavirus, but in general, it's showing that vitamin D just help prevent against either acquiring an upper respiratory infection or getting really sick from it. So
Interesting.
yeah, so vitamin D you can get from being outside for 15 minutes a day, or you can take a supplement. The chances of overdosing on vitamin D are pretty low. It's relatively safe. And then some studies are recommending in the hospitals to give IV doses of vitamin C because it attacks the free radicals that are part of that cytokine storm that young people get when they fight off COVID-19. The only problem is that the oral vitamin C doesn't really reach the level in the blood that the IV does in order to be effective. So,
Yeah.
How much vitamin C can you take? I think it's like 1,000 milligrams a day. So, I mean, if people want to feel like there's something that they can take, I mean, it's just eat regular healthy food. You could probably get a lot of these vitamins, just eat good food. Take this time to cook for yourself and eat healthy. But if there are supplements you want to take, I would say C and D.
And that's, I mean, you touch on an important point that the thing that's going to, the thing you probably have the most control over is just your general overall health. And so
Mm-hmm.
still maintaining some sort of exercise and eating well, which
Yep.
is a challenge for a lot of folks being holed up
Yeah.
at home,
Sure.
But to, yeah, absolutely stay on top of those things. And I've been looking at it as things that would probably have very little downside. Sure. I saw a week or 2 weeks ago, that J.K. Rowling, author of Harry Potter books, thought that she'd had it a few weeks back and was doing some sort of like online telemedicine or saw a video or something with some doctor who described a breathing exercise. That was basically big, deep breath, hold it for 5, exhale
Yes.
slowly, hold it for 5. And the idea with that is that theoretically you're opening up your airways a lot better and oxygenating parts of the lung. And it sounds like it makes sense. There's clearly probably not a whole lot of research behind this for this particular illness, but at the same time, learning how to take deep breaths is not going to do anything bad to you. So sure, go for it,
It'll probably help your anxiety related to this
Yeah,
too and your
that
mental
too.
health. But
Absolutely.
that's funny you mentioned that because I heard something similar and it was like if you could take those breaths, like take a deep breath in, hold it, and then let it out for I think it was like 4 to 10 seconds or something, then you're less likely to have coronavirus. I
That's
don't know
true.
if you saw that one. I I read it and then I was at work later that day and I think it was just like general anxiety like like you were mentioning what do you look for in sick patients is shortness of breath and so I think all of us at work now we're wearing an N95 and so when you're just breathing in your own you know carbon dioxide all the time you start hyperventilating
Yeah. Because for those
and
at
so we were
home
all like
who don't have one, I mean, it's a super restrictive mask. I have
not comfortable.
Nova Doc who we have 2 types in our office. We have just a handful of them, but she prefers only one type because the other type is just too tight. It's like, no, I want the tight one. That's the one that
Yeah.
is doing its job. But yeah, sorry, I interrupted. You were saying that.
No, you're exactly right. It's super tight and uncomfortable, and you're wearing it for a long period of time. And when you're breathing in all that extra carbon dioxide, it's going to make you breathe at a more rapid rate,
Yeah.
and then you get short of breath. And so we were all like trying to do that. We're like, oh, I can take a deep breath and hold it, and I don't have coronavirus. And then like a week later, somebody published on on CNN or something saying how that was like, total bogus.
Yeah.
So
Yeah.
it's crazy. There's a lot of crap out there for
There
sure.
is, and one that's been challenging, I think, to weed through for a lot of people is, and I know I get this question a lot. I'm curious in your take, is ibuprofen, right?
Oh yeah.
Definitely a mainstay in a lot of families' homes to help kids. But I don't know. What is your take on what's out there with this?
Well,
No
I mean,
pressure.
there's a lot to unpack with that. I mean, I think the bottom line is that we don't have any real evidence that it's bad.
Yeah.
Um, where that came from was there was a study out of China that patients with high blood pressure that take high blood pressure medications like ACE inhibitors, when you take that ACE inhibitor for your blood pressure, it activates this protein. This protein was thought to allow COVID-19 to get into healthy drugs. So,
Healthy cells.
healthy cells, sorry, my fault. Some researchers in Europe looked at this study and they said, okay, so when we do anti-inflammatory medications, which this high blood pressure medication is one of them, it causes an increase of this protein which allows COVID-19 to get in. That was all they said. Then the French Minister of Health tweeted, oh, let's avoid ibuprofen because ibuprofen is an anti-inflammatory drug. By correlation, 3 degrees removed, back to this original study. I mean, it was such a crazy leap, and that just like circulated like wildfire. But basically, what it comes down to is what I tell people: be concerned with more with your own body and your own medical problems, whether ibuprofen is safe. Like if you're older, if you have heart disease, if you're taking blood pressure medications, diabetes, you probably shouldn't be taking ibuprofen anyway.
Yeah.
I mean, we know like actual studies in the last couple of years have shown that ibuprofen increases your risk for, heart attacks and things like that.
Yeah.
So, I mean, Tylenol is probably safer for you. If you have gastritis, if you get, ulcers, don't take ibuprofen. Tylenol, Tylenol is generally safer, unless you're like a heavy drinker. But I think if you're young and you're healthy, you can take ibuprofen too. So I think that's the bottom line. I think it just got blown out of proportion, and by just like so many leaps and bounds that didn't. It was like not causation. It was like correlation. It didn't actually show that it was a cause and effect. It's just like two things happened, but they weren't directly related. It's crazy.
It was essentially like an international game of telephone that they just magnified this.
100%.
Yeah.
That's a good way to look at it.
So, we kind of touched on this a little bit with the antibody testing. And I half joked that I think everyone's patience is starting to run thin. But this is something they're going to be dealing with for a long time. And yet there's a lot of conversation about how can we reopen the country, the world? What's it going to take to start to reopen? What is that going to look like, and timing wise, or what steps do we need to have in place before we can really make that an actual consideration?
I mean, I like the fact that this week we had governors from, California, Oregon, Washington as a group, and then, or as I say, as a block. And then you had like the New England states, was it like New York, New Jersey, Rhode Island, Connecticut? I thought that was really important because they're recognizing that this disease doesn't care about what state you're from. Yeah. And I think that's great to look at it in a regional sense and come up with a plan to reopen. That was an important step because I think, not just in our country, but like across the world, like the response to this has been so fractured. And, now we're getting into blame, our president blaming the WHO, saying they didn't do enough, cutting off funding. I mean, exactly at the time when we needed WHO.
Yeah.
And just like people becoming super nationalistic about this and blaming different countries when we should be thinking about this globally. Like this disease affected everybody. Yeah. And if we're gonna make any improvement, it's gonna be on a global level. So as far as what it's going to take to reopen, like we mentioned before, the testing is going to be more widespread. There's going to be antibody testing. The hospitals have to be able to handle additional surges because as we open up different things, there's going to be more small little outbreaks. Mm-hmm. And the public health department has to be able to identify the source of the outbreak and their contacts through surveillance that's not, how do I say this? I want to say not like Russia.
I mean, it's going to be
confidential. What's the word?
It's going to be Big Brother in some sense, which I think is going to rub us all the wrong way. But it's, I mean, I think Apple and Google are teaming up already. There's talk about how to protect privacy while at the same time being able to really track and monitor. I heard, I think it was on NPR the other day, they were talking about in China, in some factories where they've started to reopen. In the lunchrooms, they have QR codes on the seats. And so before you sit down with your phone, you scan your QR code. And that way they are tracking who sat where on what day and at what
Wow.
time,
Wow.
which again sounds kind of crazy. But then they know that somebody
Mhm.
who tests positive 6 days later, they know exactly who they have to notify or who they have to quarantine, um, to
That's
really
amazing.
try and lock this down. And that's, especially here in the U.S., but kind of the West, I think in general, that's something that
Mhm.
you're gonna have a lot of rancor over. I think I forget where it is. Just today or yesterday, there was a protest. I think in a Midwest city
Really?
here in the U.S. Oh yeah, I mean guys with AR-15s and stuff on the steps of City Hall talking about how the governor or the mayor was overstepping their bounds with the social distancing restrictions. So I think that the things that are going to really be necessary to lock this down and keep it locked down to move forward are going to be a tough pill to swallow for many, but
Yeah,
kind
I
of
mean, this is
necessary.
the most difficult country to have to do that in,
Yeah, yeah,
because everybody just values their freedoms and their liberties. But I think you'd be surprised. I mean, my feeling is that people would be willing to surrender a little bit of personal freedom and liberty for the greater public health. And I think that's where our response was short-sighted from the beginning because they were trying to manage, how everybody would feel about it, and
yeah,
too many cooks at the stove, and then it just we were too late. So if you look at some of the authoritarian countries who just like, hey, this is how it's going to be, we're locking it down. I mean, South Korea is a great example of how it worked. And so I don't know. We're gonna have to take a hard look at our values and stuff that are important to being American and stuff. But in times like this, we have to make some sacrifices.
yeah, yeah. The question is just then going to be, when we do sort of swallow that pill, then how we then step back from that big brother,
Oh, give it
monitoring and
up
that
and
sort of
go.
thing.
Yeah.
Yeah, Um, but that's turned that a bit. I think that there are probably going to be some good things that will come out of this whole
Hmm.
experience. I personally feel that there's going to be. Um, I think a lot of us who've been home for a while and have gotten used to a quieter existence, um, are going to find, hopefully some sort of silver lining in all this. Maybe recognize that some of the things we thought we needed or needed to do, maybe we don't actually need that. I don't know. Do you see any good coming from this in the end?
I mean, from a like a global level, it's. I mean, I always think about climate change
Yeah,
and stuff
yeah,
too. I mean, it's been incredible. Like, if we even the most stringent restrictions that we came up with for the last Paris Accords, which our country subsequently left,
yeah,
would have never even equaled to the amount of good that we've done in the last month. I mean, like the limit on the CO2 emissions over the next 10, 20 years, whatever the pact was, would have never come close to what we've already done.
yeah,
um, you know you think about it in terms of that. I mean, we've given the planet a breather. And even if somebody would just come out and say, "Hey, we have a treatment, it's a cure-all today, and tomorrow we're reopening," I mean, I don't know how many people would actually just like run out there either.
yeah,
It's amazing what humans can get used to and adapt to as a norm. I mean, initially there's like that, the protest, you fight against it, and then you just kind of like give in, and then you just like adapt. And like you said, you enjoy the quiet, um, and then all of a sudden you're forced back into the reality that you had before. Like, are you gonna want to go back there?
yeah.
You know? So it'll be interesting. I don't. I mean, like I said to you before we recorded this. I mean, I think overall there will be more benefit. I mean, to everyone. There'll be more good that will come out of this. We
Yeah.
have to believe that. I mean, every pandemic, every major thing that's happened to civilization that was bad, like there was great things that came out of it, from the Spanish flu to the Dark Ages. I mean, there's always been something good that's come out of it. So,
Yeah.
I mean, I think we just have to be hopeful.
Yeah. I think so too. So I know that working in a hospital, especially in the ED, it's stressful. I mean, I think that one thing that has been pretty amazing to see is the societal response to appreciating everybody, from
Mhm.
physicians, nurses, respiratory therapists, the
Yep.
janitors in the hospital,
Yep.
the secretaries on the floor, on down to, I mean, things like working in a grocery store, all these
Mhm.
jobs that everybody thought no one really put a whole lot of praise on. I think it's been pretty
Mhm.
impressive seeing a lot of the thanks and the gratitude shown towards all the people who are doing so much to keep society going and keep us healthy. Um, there are a lot of people that I know want to help in some way. As an ED physician, what would make your life easier and the life of your colleagues? I mean, how could people help in some way?
Well, it's a good question. I mean, at least we are in Burbank. I mean, it's every day somebody donates food or
Mm,
calls in a bunch of pizzas. I mean, that's been huge because
yeah,
a lot of us have not been able to go to the store as often as everybody else is.
I bet.
Um, and yeah, by the time we went, there was definitely no toilet paper. So, um,
That's how you
but
reuse
thankfully we
some
had enough at the
supplies.
hospital. Yeah, yeah. Um, it's a tough question. I mean, I think, the in the bigger city, I mean, Los Angeles is super sprawled out, right? But I mean, they still do the 8 o'clock clap, um,
Yeah,
like they do in New York. And just knowing that's happening and that people are supportive. In Burbank today, the fire department and the Glendale Fire Department did this huge parade with all their trucks,
mm,
with their lights on and everything to show their support. And one of my colleagues was saying the other day, like, we hope this is a return to trusting doctors and scientists again,
yeah,
because it seemed like for the last few years there's been this kind of like push away from that, people being anti-vaccine, whatever. I can't imagine that argument will have any legs to stand on after this. Um, so hopefully people will look to doctors and scientists as maybe these people need to be the politicians and the ones in charge and making the decisions and like leading the country in
yeah,
a sense. Because this could have been just a warm up. I mean, what are we going to do with climate change after this and stuff? And so, I think that's what we want. I think we just want to be recognized for what we know and, you know, what we're trying to do.
yeah. Yeah, there's been a great little meme going around about, you know, all the folks who told you that coronavirus was a hoax, or the same people who told you that climate change was a hoax. So, how's that looking? Um,
Yeah.
yeah.
Touche.
Right?
Yeah.
You mentioned meals, and I want to do a quick plug. My uncle, actually, Marty Pico, has been involved in creating a really great website called covid-meals.org. I'll have it linked up in the show notes. And what's really cool about it is that it links hospitals and local restaurants, so that people can pitch in money and donate
Sweet.
food from local restaurants to
Okay.
hospitals, and that way you're feeding everybody working in the medical front lines, but also keeping the local restaurants in business.
Awesome.
Yeah, they've got a lot set up in California, and they're
Really? It's
starting to.
nationwide?
Well, he's in Santa Cruz, and so it started off in Santa Cruz
Mm,
area, but
okay.
they've now opened it up so that if people in other parts of the country want to get either their local restaurants or their hospitals involved, there's a quick little form you fill out, and he reaches out and helps you set that up.
Really?
Yeah.
I'm totally doing that.
Yeah, covid-meals.org. It's pretty awesome.
Okay, that's
All
so
right.
the hospitals reach out and then he like finds the participating restaurants in the area. Is that?
So all the different levels can reach out, whether you are a
Mm,
restaurant, healthcare worker, or just somebody who wants to bring it to your area and figure out how to pitch in and help out. Yeah,
awesome.
pretty cool,
That would be huge.
right?
Yeah, thanks to your uncle.
Yeah, he's pretty awesome. All right, so once again, people can find you on Instagram at Dr. Daignault. It's at DrDaignault, right? I had to look over at my notes to remember that.
You nailed it.
I'll have that flash up on a screen on the video, and for the podcast, I'll have it linked up in the show notes. Um, but yeah, man, thanks so much, brother, for coming back. This has been really helpful, and
Yeah,
stay safe out there. Thanks for everything you're doing.
you
And,
too.
and
We'll have to touch base again and see where we're at.
that's right. That's right. All
All
right.
right. Thanks, man.
Yeah, absolutely.